Okay, we're a bit tight for time, so what I'm not going to do is run through all the slides. So I'd much rather take 10 minutes, share some of my personal views, and then I think actually get into a bit of debate and some questions. So this is basically future of commissioning support services. Where's it going to go? We just published yesterday our strategy for developing commissioning support services. It's on the website, but at vast expense there are actually some hard copies on the NHS England commissioning support stand. We gave away I think about 400 yesterday and we've broken the budget, but there are copies there if you want them. Where does all this come from and why, as Charles has said, this is important stuff? Well, it's important because if you have followed some of the debate over the last few weeks around the NHS England strategy, the issues around challenges to the sustainability of the NHS, you have to conclude that whilst actually we are all collectively about wanting to improve outcomes, and we still have a long way to go in many outcomes compared to most of Western Europe. We want to reduce inequalities, but frankly the current shape of our delivery system is not sustainable in the medium term. And you see evidence of that all over the place around urgent and emergency care, frail older people, complex multiple problems, end-of-life care and so on. So if you look at that, you have to conclude that we need service transformation at scale and at pace if we're going to actually secure a sustainable, successful NHS that actually delivers improved outcomes but also actually takes the public with us in terms of service. So what does that mean for commissioning? Well, it means we need a commissioning system, so direct commissioners, CCGs, CSUs and others who are capable of doing two big things. And it is a huge challenge. One is securing quality today, and people tend to overlook amongst the range of recommendations from Francis some very hard specific ones about CCGs have a responsibility now to identify poor quality services and use contractual and other mechanisms to actually improve services. So you need to do that, but commissioners also need to lead clinically the transformation of services for tomorrow. And that's not tomorrow as in mañana, it actually is tomorrow as in the next 2 or 3 years. Unless we start to deliver that transformation, we risk getting locked into a cycle of challenges to quality and resourcing. So we've taken a view, we think we're probably right, but that may be me being arrogant, that actually to improve outcomes and experience for patients, we need commissioners who can secure quality now and lead transformation. What does that mean? It means making a success of strong, clinically led, localized commissioning. So an absolute commitment to supporting CCGs. In doing that though, making sure they can access professional, high quality commissioning support. We need to ensure that commissioners and commissioning support services access and use evidence-based practice and draw on what works. And in response to the challenge, well, on some of the key areas, actually the evidence is limited. Well, it is on intermediate care and actually shifting services, but it's good enough. You know what you can make to work, and some of this is actually about, in fact, trying it out locally. I think we need lean-focused CCGs who actually add value through what they are best set up to do, which is effective local clinical leadership and engagement with fellow clinicians, with the public, with patients, and actually with local politicians. It's about actually also, though, one way or the other, otherwise I'm going to risk a challenge from Charles, whether CCGs provide their services largely in-house or buy-in or somewhere in between, how CSUs collaborate or not, we need to find a way in the system whereby commissioners get the benefits of commissioning at scale, those things that make sense at scale, without detracting from actually localized commissioning and local decision making. And that means really actually we need to keep the transaction costs down. You look at what's actually going to happen to the cost envelope for commissioning over the next few years, it is going to reduce steadily. So we need to make sure that we're all getting the best value out of commissioning support. So that's basically informed the strategy you've seen today and yesterday and our strategy for developing CCGs. These are the benefits we think really good commissioning support can deliver. So actually, if I'm looking for my vision for 2016 and not talking about the structural stuff, By 2016, I think brilliant commissioning support would free up clinical commissioners to add on where they add most value. That's the supporting clinical leadership, improved pathways, strengthening procurement practice, the contract stuff and quality, using much better business intelligence to secure improvement. I, wandering around, have seen some really interesting stuff in terms of BI systems, for example, to actually develop real-time scorecards on urgent care, the new Aristotle system. There's some really interesting stuff going on there about actually using business intelligence to drive quality and efficiency. It's about enabling commissioners to deliver large-scale improvements. And one of the things I guess I'd say there is in 2 or 3 years' time, I think will have failed if most CCGs, and I do mean most CCGs, aren't actually moving significantly into outcome-based commissioning for key populations like frail older people, like end-of-life care. And secondly, they're not only doing that, which is quite a radical approach on commissioning, they're starting to get some benefits. So I think that's that big challenge. You know, where is all the pressure actually on quality and demand and so on? It's in those key population groups. And CCGs are not going to do that on their own, but I see some really good examples, like in Staffordshire, of CCGs who've rolled their sleeves up, are working with their CSU and are serious about using things like COBIC, other approaches to actually outcomes, to drive change and frankly challenge providers. One of the other things I'd really look for is that actually we stop doing things in boxes, and that actually the CCG community, the CSU community and NHS IQ are making sure that everybody has got access to the best practice in terms of transformational change and what works. That we start actually mobilizing service improvement at scale, not just in terms of penny packets. And that, to be honest, we get the economies of scale we need. So, I'm not going to go through the market-based approach. The guts of our strategy is this isn't going to work because everybody's at an early stage of development unless we try and do 3 things simultaneously. We need to work with CCGs. CCGs are very different, but to actually build awareness of their need for commissioning support, to make sure you've got access to the right choices, the procurement system is as easy as possible, and you know how to recognize best value, and at times you actually act collaboratively to get the best value out of your providers. We need to work with the providers, particularly the CSUs, to actually make sure they're the best possible, so we've got excellent commissioning support. Again, they won't do that on their own, they need to actually form partners. Yesterday we announced the deal with Akivo and all the CSUs where they can draw on expertise around patient and public involvement, service redesign from folk like Macmillan, Marie Curie, Age UK and so on, which is a huge step forward. But we need the best possible providers to actually give you the best services, and then we just need to make sure that the mechanisms we use around procurement are as simple as possible and don't get in the way, and more to the point, do 2 things. That they're set up to ensure you can get access to the best services, because that's the whole point of this, and secondly, they reinforce this is all actually about CCG choice and putting CCGs in the position of deciding what they want. Okay, so that's sort of where we are. I've given you a bit of a vision in terms of what it might look like in 2016. I'll just talk a bit about the structural stuff. So by 2016, we have a commitment for all the CSUs to have moved out of hosting, i.e. ownership and control, by NHS England. We are currently working through the options for that and the approach. We're engaging again with CCGs, because I think customers will have strong views on this, and the CSUs and other providers and their staff over the summer. And then we'll look in November to take to NHS England's board a strategy for creating autonomous CSUs. And they could become social enterprises, they could become actually limited companies, there are ranges of options. But we need to make sure we use the summer and the autumn to actually get that right, so we manage change sensibly, and we ensure that whatever we do on creating autonomous CSUs goes all the way back to the point of this, which is actually making CCGs have access to the best possible support, because frankly that's really ultimately all that matters if CCGs and direct commissioners are to deliver for patients. So we will be engaging with folk over the summer and the autumn over that. We'll keep you involved. If that's an agenda you're interested in along with the CSS one, then if you register at the NHS England stand, we'll make sure you're involved, either when we're coming out to see you at CCGs on procurement stuff and so on, but also actually on the autonomy agenda. I think in terms of timing, I'll probably stop, Charles, now, and I'm happy to take any questions on anything vaguely around this agenda.
A real insight as to what is possible in terms of how CSUs are going to develop and how commissioning in general is going to develop. And I think it's a real opportunity we have to ask the questions, even the stupid questions that we, in many respects, are afraid to ask around what does this mean, this business of competition? What is the effect of having such a mixed marketplace? Around the commissioning of services and the support around the commissioning of services. So this is your opportunity to ask the questions you need to. And if people would like to start asking questions, I'll take questions as they come in. But I'll start off really by asking a question which is perhaps a little bit left field, but you expect that from me. And I'm talking about the responsibilities of CCGs themselves. They have a responsibility to procure the best possible commissioning support for their populations. Now, is there a duty for CCGs to ensure that is indeed the case? And let's take a purely hypothetical situation where a CCG decides, for reasons which are perhaps different from the reasons around the procurement of the best possible service for a population, that they wish to keep everything in-house because it's easier. What would the system feel about that, and would there be some ways in which that could be managed?
Yes. So clearly, if a CCG wanted to provide everything in-house, then that's its choice. So it's got a right to do that. However, there are some responsibilities that go with that. The first thing is working through, in quite a systematic way, and reviewing your decision on, do I build, do I share actually with other CCGs, or do I buy in either from your CSU or from somebody else? So I think the first thing is that actually I would encourage all CCGs over the next 3 or 4 months just to give some thought to, did I get that initial decision right? And as the scale of the challenge emerges over the next 3 or 4 years on quality and transformation of services and so on, if I'm trying to do everything in-house, that might be fine for the contractual stuff or patient engagement. I think I'd be deeply skeptical on the ability of any CCG on its own, or any CSU without partnering, to actually be able to deliver the really good support on transformation. So what do I mean? You know, that ability to actually do the diagnosis, for which you need really good analytics, the ability to engage. Now, frankly, that if a CCG can't do the clinical and public engagement bit, they've got a problem, but they may want to buy that in. Working through to, well, actually, what's best practice? What are my options? How do I turn that actually into the sort of contracts that will drive change, like COBIC or whatever? Then through to, do I really want to program manage all the steps involved in transformation? Now, the answer to all of those may be, I think I can do it in-house, but I think at the very least, there's a responsibility to work through that process and do it in an informed way that you're aware of what the options out there and so on. So it's down to CCGs. I would, however, and I'll make myself unpopular here, I think there needs to be some challenge. So I think in audit terms, there is a risk that actually you get very bad value for money. So therefore, the auditors of a CCG, I think, should be asking some questions around, is this good value or not? I think the second thing is actually, in fact, and is the CCG making good progress on improving services for patients? Now, if the answer is it's doing all that stuff, then absolutely fine, but it wouldn't be acceptable for a CCG to say, I'm going to do it in-house, and then you find, lo and behold, they're not doing transformation, they're not working with their neighbours to deliver.
Okay. Sorry, I'm going to take a supplementary here. I'm going to probe you a little bit further, because this is interesting. I think I understand the duty of a CCG to manage its population, and I really think to get the best for its population. I really get that. And the fact that it is public money it's very important we have a process to ensure that is appropriate, proportionate, and the rest. Get that. Now, I think we need the same degree of scrutiny if CCGs choose to use the incumbents they always have without thinking around whether the incumbents they always have are the right people to have. So there is a law of proportionality, I think, which comes in here, whereby we need to be equally to have an equal degree of scrutiny around the CCGs, around what they are doing to themselves, but also around how they are procuring. So will there be the same level of scrutiny on CCGs to ensure that they have actually had thinking around whether they have the right CSU?
Yes. So I mean, we're going out to have discussions over the next couple of months around actually how CCGs would procure to enable choice and all that stuff. But my view is if you agree that commissioning can make a difference to patients and taxpayers, which I believe in, and if you believe that actually, frankly, we need really good clinical commissioners but backed up by the right support, then I think it matters that whether the support is in-house or bought in or a mix of, that actually CCGs have thought about what they need, and also in terms of providers, there's sufficient challenge. So one of the things we've suggested is the idea of a lead provider framework for those CCGs who might want to buy in many of their services from one provider, maybe on a longer term contract, so you've got partnership. That is absolutely great, but that provider's got to be very good. So we're suggesting there needs to be a rigorous accreditation process, so whoever you choose to buy your service on, you know they are good at the whole range of services, and either they're good because they've got good in-house folk and analytics, or they're networked with other CSUs, or they're bringing in Age UK, Macmillan, or they're networked with commercial providers. So I think it needs to be equally rigorous on both sides, customers and actually providers, if we're going to get in the best quality commissioning support. And I really do think we're in a situation where we either need to demonstrate commissioning is going to deliver over the next 2 or 3 years, or they're going to be two difficult consequences. One is around actually we won't deliver the transformation, we'll fail for patients. And then secondly, you'll get what I think this is quite insidious chatter around, well actually, can commissioning ever work? I think it can work if you empower commissioners and you get the tools right. But it's really important, I think, there's enough rigor and challenge on both sides, and I know that will be uncomfortable, and I know CCGs and CSUs have got lots of other things to do, but I think it needs to be rigorous if we think commissioning can make a difference.
Thank you. I think that really did answer the question in terms of proportionality quite well. Any questions from the floor? I'm looking at a journalist in the 4th row, who I'm very surprised, that's you, yes, has kept quiet, because he very rarely keeps quiet when I'm around, so this is your opportunity,
That's
David.
Seriously unfair.
Life is unfair.
It's a question for Bob, unfortunately, Bob. Actually picking up on Charles's last point about, and the point that you made about challenging CCGs, the quality of CCGs in-house provision. I wish I had a copy of your report to hand, but there's a section about how you're going to do that, how you're going to assure the quality of CCG in-house provision. Yeah. And there's a line about how you'd be doing that for the interests of patients and system interests. There's kind of two, I think the phrase is system interests. Can you describe what those system interests are? Sorry, say again, I missed the last bit. The acoustics here are awful. Okay, sorry.
I got as far as actually how you're going to assure the quality of in-house.
So can you, the phrase in your report is that you would be assuring those in-house services for patient interests and system interests. I'm fairly sure the phrase is system interests. Can you explain what those system interests are?
Sorry. Yeah, okay. Patient interests are fairly straightforward. Either actually a CCG is commissioning well or not. There's a taxpayer one around actually, and are they spending a disproportionate chunk of taxpayers' money inappropriately on expensive in-house provision? There's also actually a system interest one, which I think is tricky, and it's why we're going to be engaging with Charles and his colleagues over the summer, and we're going to have a behind closed doors discussion around this stuff, in terms of if a CCG decides you want to pull it all in-house and the effect of that is to devastate the services for their neighbours, then I think there's a system interest in terms of managing risk. That's not to say you can't go in-house, but CCGs need to actually behave responsibly. but without NHS England, if you like, being heavy-handed and bureaucratic. So that's why we've said actually we want to go and hide with some CCGs and say, let's work through what's a sensible, proportionate approach to benchmarking, to making sure that CCGs take informed decisions, and then we'll go out actually, in fact, and share that. It's a sensitive issue, but if we don't grasp that, I don't think we'll actually, in fact, be doing anybody any good. So it's about this issue of benchmarking informed decisions, but also taking into account the effects on that wider system, whether it's their CCG neighbours or actually what happens then in terms of costs and liabilities around commissioning support. Did you want to challenge that?
No, I don't really want to challenge that. I think that's actually quite as always, quite a difficult area because there is a real issue around proportion here again. Exactly. But I think it can work as long as one doesn't assume that change will inevitably lead to a degradation of a service in the locality, because the way that some people understand that is you can never change anything because it will inevitably mean loss of income to somebody who is in existence, so we can't do anything. I think people need to be challenged, including the CSUs themselves, on occasions, around the fact that if they are losing market share dramatically because people are choosing to go to other places for a whole variety of reasons, but partly perhaps because they don't deliver the service which people require, there needs to be a planned diminution in scale and size of that organization commensurate with what the demand for that organization is. We haven't seen that from hospitals because it's the same sort of process. We need to develop a way to ensure we manage that. I think the key is going to be the amount of time that is going to take. And the discussion will be, is that a 1-year job, a 3-year job, a 4-year job? But I think we need to be very clear that it is a job that has to happen, and not because it means change, we can't do it. Because if we end there, I really don't think we'll get to a very good place.
No, I think that's right. So what I would say is that we have the opportunity during hosting, which lasts to 2016, to actually introduce a market, to use it to drive up quality, to actually make sure CCGs have choice and so on. But it is a managed approach. So I am not advocating a free market, free for all, because commissioning matters too much for that. So we're going to have a managed approach, which means that actually if providers are coming under increasing pressure, we need to manage the consequences and work with them. And that's the price of actually making sure that no CCG is left without a service, because that's really important and the quality doesn't nosedive. But it needs to be a managed approach, but which works from the basic principle of CSS is so important, we must have the highest quality providers, and that's quite hard. But secondly also, we have actually given CCGs the right to choose where they provide the service. But it does need to be a managed approach as we work our way through this, and that may mean at times saying to some CCGs, actually, do you realize the consequences of this? You need to work with us.
I think that's very, very constructive. I'm going to build on that theme a little because there is another opportunity here, and one which CSUs really start to have to think through, because there is a potential for outsourcing to really start to happen. We have a very bad history of outsourcing in primary care. In the past, what tended to happen, not always, but I'm going to exaggerate to make a point, is that the outsourcing was organized by another organization, and the outsourcing organization which was supposed to support us looked to another organization as the organization which it responded to. So we were often in receipt of services which were supposedly directed at us, but actually looking somewhere else. And this has led to a culture where people never outsource because it never works. Outsourcing can work if CSUs understand that CCGs inevitably need a whole level of skills which they potentially can't ever really satisfy in-house. They can start to supply a whole series of disciplines and back office functions which CCGs can share. And share in a way whereby they remain the customer. They remain the only important person and organization within this, not, and I'm going to again be a little bit disrespectful, not an SHA as has happened in the past. They don't exist anymore, so I can be disrespectful about them.
Okay. I think Charles makes a really important point. So the one thing on all this agenda that made the headline in the HSJ yesterday, for which thank you very much, was actually that we would force CSUs in terms of qualifying for any framework. If they can't provide in-house, they're going to have to actually go and subcontract, outsource to the best possible folk. And I read that through and I thought, oh, great. And then I thought, actually, if you're a CCG, that's quite reassuring. It actually means we are going to ensure that one way or the other, the CSUs who are providing those contracts are the best you can get. And that's either in-house or bought in or through collaboration. We need to move towards a culture that says you don't have to do everything yourself. You really ought to be collaborating on those things that actually make sense. You should be buying in, bringing in skills, whether it's voluntary sector, commercial and so on. And we need to also encourage those CCGs who are mainly providing in-house, again, to think like that. So in the end, I actually thought it was quite a helpful HSJ headline in terms of we are serious about making sure CCGs can access the best in breed of CSS. Now, I apologise for that, but I breed dogs, so Preston breed is a good analogy.
Thank you, and I can't think of a better analogy to finish off on best of breed. That's really what we hope CSUs are going to end up as, to ensure that CCGs are also best of breed. So thank you very much for spending the time with us this afternoon, and I think there are some further sessions in around here, so perhaps you'll remain or you'll move. Thank you.